Hi Ninja Nerds! In this video today we're going to be talking about glomerular filtration rate. So if you do like this video, please make sure go down, hit that subscribe button, comment, and don't forget to hit a like. Also, go check out ninjanerd.org. That's where all of our notes and illustrations for every video that we do put up here on YouTube are available for you guys to utilize. So let's talk about glomerular filtration rate, also known as GFR. Now through our renal series, what we've been touching on is what are the labs of the renal system? What are the different types of physical components in the anatomy and physiology that we need to know? So let's quick go over the anatomy and physiology of the renal corpuscle here, where we have our two arterioles that are coming into our glomerulus. So here's our glomerulus, right? So we have our glomerulus, and then we have our afferent arteriole that's bringing our blood in to get filtered, right? And then we have blood that's going to be exiting through our efferent arteriole. And then down here we have our Bowman's capsule. All right, our Bowman's capsule. Okay, so when we're looking at this, just to quick reiterate what's happening here, we have blood coming in. It's going to go through a series of exchanges and filtration here, and then it essentially exit. When this series of exchanges and filtration occurs, we then start to generate filtrate. And the filtrate is going to go down through the renal tubule and eventually become urine, right? So let's think about that for a second. When we have filtration occurring within our glomerulus, it essentially creates filtrate, and over the process that essentially becomes urine. And there's lots of different things that occur, but that is a very basic answer to what is occurring here. Now, before we talk about all the different types and components that happen within our filtration membrane and how we get out, I want you just to think about what consists of our filtrate. What is getting changed here? Because if we think back to our beginning of our videos with these arterioles, usually when we have a capillary bed, we have a drop-off of an exchange of oxygen and an exchange of CO2. This capillary bed, we are not doing that, right? So we still have an afferent arteriole capillary bed and then another arteriole, efferent arteriole. So the exchange or the filtration that is occurring here is other substances. So we're not going to be talking about gases, but what are other things that will occur in our filtrate? Let's first think about the most basic, which is H2O or water, right? That's a very abundant thing that we're going to be finding within our filtrate. We can also think about our electrolytes. So think about our sodium, our potassium, our calcium, our chloride, our magnesium, right? All of those different types of electrolytes could be available within our urine, right? What else can be filtered? We can think about things like hormones, right? We can think about toxins or different excess amounts of drugs that could be within our blood, because we want to get rid of those. We want to clean this blood, filter it out. We also can start thinking about our creatinine or urea. We also can look at other things like glucose or amino acids, right? So all of these things essentially getting filtered, become urine, and then we get rid of them. So if it's excess things that we don't need, we're going to get rid of them in our urine. It's a waste product. But what you're noticing here is that there's not things that when we do run some type of urine test on our patients, we're going to say, oh, if this is present in abundance or if this is a presence at all in the urine, there might be something going wrong, right? There might be something that's affected within this filtration. So those would be those big things, like our red blood cells, right? We can also think of things like our white blood cells. We can also think about various different amounts of proteins. Now, some proteins are small enough to get filtered through, but some aren't. Some are really big, and we want to keep those in our bloodstream. So to understand this a little bit further, let's talk about the pathophysiology of the filtration membrane. So within this diagram right here I drew, you can see this purple, blue, pink layer. It coordinates with their names, so hope that's easy. And it's also up here. You can see the purple here is our glomerulus. Then we have our blue underneath it, which is the basement membrane of the glomerulus. And then we have the podocytes, which is essentially the beginning of the Bowman's capsule. Okay, so let's go through and identify really quickly how the filtration membrane works. For me, in my head, I picture it as a couple different things that are occurring. This is the largest area, the fenestrated endothelium, is going to let the largest, smallest molecules, I know that's confusing, right? So things that are really small, we're talking nanometers, we're talking about really, really small things right now. They are going to get through here, and then if they are small enough to get through the next layer, that's phase 2, they can get through, and then if they're small enough, they're going to get through phase 3. So let's back it up and first talk about the fenestrated endothelium. The fenestrated endothelium, right, is this layer right here within our glomerulus. So it's part of the glomerulus. Okay, and the glomerulus has what? I mean, the fenestrated endothelium has what? These little openings right here. What are these? These are called pores or fenestrations. And what this is going to do is this is going to allow things that are small enough to fit through to go through these pores and essentially go to the next step. Okay, so things that are too big, like our red blood cells and certain proteins, are going to stay within the capillary bed and then get filtered back into the body, right, and go through the efferent arteriole. So the little things that possibly go through is what we talked about here in our filtrate. When they get to this second layer here, this one what we're looking at here, our basement membrane. Our basement membrane, if you look at, okay, it's got a collagen makeup. It's actually dense in the center, but the most important part about this, and the main thing you need to know about it, besides all of its different layers, is that it has a negative charge. So that negative charge, if we think back to all the things that we have learned in science, especially back in like high school, is that a negative charge will repel a negative charge. So if there's anything that is trying to get through that might have fit through but then is negatively charged, for example, albumin, it would go back into our blood circulation and out our efferent arteriole, because we want to keep albumin in our body, right? We want to keep that so that we're able to stop those leaky vessels and transport certain things that we need to. Then once that filtrate or potential filtrate makeup, all these little things that we talked about up here, start to get through, they get through our fenestrated endothelium, they get through our basement membrane. Now we're looking at our podocytes. So these are the footed processes of the podocytes. And there's a lot of anatomy within the podocytes. I just want you to understand that they are tightly together. There are these little slits that are going to allow some things to cycle through. And as they get through here, then we are essentially making into our renal corpuscle and start making our filtrate, okay? So these have small little slits between each one, and they are essentially our filtration point and the footed processes of the podocytes as well. So that is how we get stuff that is in our blood that is coming through our afferent arteriole into our glomerulus, our capillary bed here, and then out our efferent. When they're in the glomerulus, that is where all that filtration is occurring. They have to get through these 3 steps. It's a little more complicated than what I brushed over there. But for this understanding of nursing is that if we have an issue with our glomerulus, or we have an issue anywhere in here, then that's where we're going to see the presence of things that we potentially don't want to see in urine, like red blood cells, like a high level of proteins. So now that we understand this, let's talk about the glomerular filtration rate in itself. So now let's talk about GFR, or glomerular filtration rate. Why is that important? So we talked about how filtration works, but what is the filtration rate? The rate is at which the blood is filtered per minute, right, within our glomerulus. So the GFR, or the number that we're going to be looking for on a patient, is typically anywhere 90 to 120. That's can change through policies, through procedures in different facilities, but I want you to understand this is generally what we're looking at here. And when it is increased, it's not as much as a concern, but when it's decreased, that's when we can start have indications of kidney disease, okay? So I'm just gonna walk you through here a little bit on what kind of factors could be changing or altering our GFR. And I think if you understand this portion, then understanding the signs and symptoms and the interventions that you can implement for your patients make a lot more sense. So again, we have our glomerulus here, right? So we have our glomerulus here with our afferent and our efferent arteriole. Right, so afferent, efferent. And then we have our Bowman's capsule. Okay, and what's important here is I want you to picture, instead of this, like you're thinking, okay, afferent arterial, efferent arterial, and then we have this glomerulus in the middle. You can think it as even something a little simpler. The way I like picture it in my head, or I like to imagine it, is that you have a hose that's going to bring water into this area, and then one that's going to bring water away. And then if you picture in maybe this like little balloon or ball or whatever, there's these little openings, these little pores, right? That's where our filtration is going to occur. I think it helps with understanding filtration rate, right? Which is occurring essentially right here on this side of the glomerulus. I mean, all sides, but in this diagram right here. So when GFR is increased, we're going to talk specifically about blood volume. What would happen for blood volume in order for it to be increased, in order for GFR to be increased? Is our blood volume going to be decreased or increased? And you want to be thinking it's going to be increased. Let's use blue. So if our blood volume increases, that's going to increase our GFR. Why? If we have more blood, right, more blood is going to be crossing over this barrier here. It's going to be circulating through here. That's going to give more chance for filtration. So the more blood that's here, the more filtration is going to occur. Therefore, we're going to have an increased GFR. Blood pressure. If someone's having an increase or decrease in blood pressure, which one is going to increase our GFR? That is going to be an increased blood pressure. Why? Increased blood pressure does what? Increasing of blood pressure causes pressure on the walls of those blood vessels, right? So if you think about all this increased pressure on these blood vessels, that increased pressure is happening here in these little capillaries, because remember, this is a capillary bed. So all these tiny little capillaries are having this increased pressure, right? And this increased pressure is going to increase the filtration rate. So it's going to increase all of that filtration that's occurring. Afferent arterial. Now this, when we talk about our different types of blood vessels, we can also talk about the difference between something that is going to dilate, right? And something that is going to constrict, right? So if we want to increase GFR, we want GFR to be increased. Our afferent arterial, is it going to squeeze really tight for blood to flow through, or is it going to open up and dilate? And you should be saying dilate. So our afferent arterial is going to dilate. It's going to open up. Why? That's going to increase blood flow to the area. It's going to allow more blood to get into the glomerulus and therefore increase our filtration rate. Same thing also occurs here if we look at our efferent. If we want blood to hang out in here longer, are we going to have our efferent arterial dilate or contract? So remember, this is our exiting point. If it's wide open, then this blood is going to be flowing through. But if it's constricted and nice and small, it's going to make that blood hang out here a little longer. It's going to hang out in that area. It's going to be able to filtrate a little longer. So our efferent is going to constrict, right? Let's look at this real quickly again. If we increase our blood volume within our body and in our glomerulus, we're going to have an increase in GFR. Increase our blood pressure, there's more pressure on those vessel walls, increase in our GFR. If our afferent arterial starts to dilate, opens up, allows more blood flow to go through into our glomerulus, great, that's an increase in our GFR. And if their efferent arterial begins to constrict or close off, it's not going to allow blood to flow out as easily, so it's going to hang out here more, also going to increase our GFR. Now if you look at it on the other side, we're going to talk about decrease, right? And you're going to notice that it starts off relatively the same, and then we got a couple extra things at the bottom here. So decreased GFR. So we're decreasing the rate per minute, or the milliliter per minute, that is being filtered. So if we have blood volume that is, you should be already thinking this through, decreased, we're going to have a decreased GFR, right? We're not going to have the same liters of blood in our body, or milliliters, so therefore the less milliliter is also going to indicate a lower GFR. Blood pressure, that pressure on those vessel walls. If it is decreased, there's not going to be any added pressure to the vessel walls in here. Therefore, we're going to have a decrease in that filtration rate. Now our afferent arterial. Our afferent arterial, if we're decreasing our filtration rate's going down. That means we're going to have less, essentially, blood or pressure to this area. So what's going to occur with our afferent arterial? It's going to constrict, right? And you can start to understand what's happening from the left side here to our right side, right? Increase versus decrease. And then our efferent arterial, we talked about it before. Efferent arterial is our exiting point of blood. If it's exiting really easily and it's all dilated, that means it's passing through really quickly, right? So this blood's not hanging out here as often, therefore it's passing by really quickly, so we're not getting that nice exchange, right? So dilate. Now, two other things that can also really change the GFR, particularly decrease it, is our renal artery stenosis. What's our renal artery? We didn't say that yet in this video. It's the artery that's bringing blood to the kidney. So if there's stenosis, if there's a stiffness and it becomes stenotic, then what we're looking at here is a decrease in the GFR. It's going to decrease overall flow, right? And then chronic kidney disease. When we're looking at kidney disease, we want to think glomerulonephritis, some damage to the area, some inflammation to the area that is causing some irritation or issue with our filtration rate here. So because of that, that could be decreasing. So take a second and look at this in a whole and to understand that if we're increasing something, like if we're increasing our blood volume, we can increase our glomerular filtration rate. But if we decrease our blood volume, or if we're having some type of hemorrhage where all these things start to drop, right? And then you can start to think about how this affects patients that have other issues that are going on. Like they start to go into severe dilation all over. They start having other third spacing of edema and things like that. This can cause a lot of big issues. So now that we understand how glomerular filtration rate works, what is our patient going to look like? What are those clinical manifestations that we're going to be looking for in our patients in order to say, okay, maybe there's something else going on? And then we're going to talk about how we are able to diagnose if the patient's, what kind of severity this patient's having with the glomerular filtration and with kidney issues. So now let's talk about some complaints that our patients may come in with, or manifestations that we might see as we're taking care of somebody, and we might start thinking, something's going on maybe with their glomerular filtration. Something's going on with this patient's kidneys. So the first sign and symptom might even be that this patient is asymptomatic. They're not having issues, but then we go further and look at some blood work and their GFR maybe is a little decreased, or there's something else going on, and we're seeing a little bit of changes. But as time progresses, or as other issues come up, there may be other signs and symptoms, clinical manifestations, or things that we see, and we start thinking, hey, there might be something else going on with this patient. So first, let's look right up here. We have the first sign and symptom. Remember, glomerular filtration rate is filtering blood, right? We're filtering things out of blood to make urine. So anywhere within that making urine problem can occur, we could have some signs. And one of them is just a decrease in our urine output. The urine output starts to decrease, right? Or change, we should say. So because of that change in the urine output, then we can start think, okay, if there's an issue with the I's and O's, are they holding on to that fluid? Probably. So we could be thinking of, is there edema anywhere, right? They might be saying, my feet are swollen, usually at the end of the day, or I'm waking up with swollen feet, things like that. They could also be saying they are short of breath, right? We're going to start thinking about that pulmonary edema. They're having trouble just going up the steps, taking them a little longer to get to the end, or the long walks, they can't do them anymore right now. I don't know why. Could be something even more simple as like they are just feeling fatigue, right? They could be feeling like groggy or altered a little bit, like they just feel like they're not thinking clearly, so they get like a foggy thought process. And we want to start thinking about it's because we're not filtering out things that we need to. Remember, the whole purpose of this is to filter out waste or filter out excess things that we don't need within our blood. So if we're not filtering those things out, right, there's a decrease in filtering. Because of that, we are going to start seeing an increase in toxins, right? That could be causing an altered mental. We could be seeing an increase in electrolytes. One that they always like to hit on the NCLEX is this one right here. We have our QRS, PQRS complex right here. So we're looking at an EKG or a densitometry of a patient, and we see this right here. So what is this? We got our PQRS, right? And then all of a sudden we have this right here, T. What's that? That's a spiked T wave. What is that for? Hypertension. kalemia. So if this patient's having an increase in electrolytes that we're not getting out, now we're going to have an increase in our potassium. Our potassium could show up in our telemetry all of a sudden as a spiked T wave, right? And then could cause issues down the line. So when we're looking at these things, they're not necessarily pointing us in the direction of, right, there's definitely something wrong with this person's GFR, there's definitely something wrong with their kidneys, but it starts the ball rolling of, okay, is there something else going on with them? From there, we can do some of our blood work. Remember when we're looking at this blood work, we talked about these in our renal labs. We have our creatinine, our BUN, and our GFR, which we have our creatinine, right, which is our muscle breakdown byproduct, right? So as our muscles break down, we can see this in the blood. We have our BUN, or our blood urine nitrogen. It's a breakdown of the proteins through the liver, right? So we can see that in there as well. That could be 7 to 20 milligrams deciliter. And then we have our GFR, which we talked about before. Can be anywhere from 90 to 120, right? Our glomerular filtration rate, milliliters per minute. So we look at all these, we take them into consideration. And then there's a test that the NCLEX likes to hit on. It's a nice one that they talk about. It's that creatinine clearance. You're going to hear this one over and over again in the renal series. What is the creatinine clearance? The creatinine clearance is, I always think of it as the pee on ice test, right? Now you're not peeing directly on ice, but you're keeping urine at the bedside on ice or at home, wherever they're doing it. So how do we do the creatinine clearance, or why are we doing this? We're doing this for a 24-hour creatinine catch. Okay, what that means is the patient is going to wake up and pee, urinate, right? From there starts our clock of 24 hours, right? For the next 24 hours, we are going to collect urine, okay? So whether you use a urinal at the bedside and then you put it on ice, okay? You could do different things with the hat for females. If there's a Foley bag, make sure the Foley bag is clean on the outside. You could put the Foley bag within ice and then just keep getting fresh Foley bags, putting them on ice. The whole goal of this is once we collect the urine for 24 hours, and then there also will get a blood test. We are going to be able to see over that 24-hour period what is happening with our creatinine clearance, what is our creatinine levels, and is this indicative of something else going on with the patient, okay? So most important thing is that ice. So let me make sure we have that word written right there, is that this needs to be on ice, okay? Without that, it's just going to ruin the test. So we want to make sure we're keeping it as cool as possible so that we're able to get a nice clear reading on what our creatinine level is. So there's other diagnostic tests that they can go through. These are just the overarching view, because remember, we're starting this from the beginning here. We don't know what's wrong with this patient. This patient has just got some nondescript complaints, and then throughout the rest of the videos, we're going to get into each specific individual type of problem. So we have a patient that we're kind of just caring for still, right? They maybe have something wrong with their kidneys. We're not quite sure yet. So what are some nursing interventions or education that we're going to give this patient in order to hopefully find an answer for them, or at least keep them safe for now until we do have that answer? So let's talk about those now. All right, engineers, so now let's talk about some of the nursing interventions that we're going to implement for these patients that we're potentially thinking there's something going on, but we don't quite know yet. And again, these are nursing interventions that can apply to any patient, but these are just ones that are more pertinent to what we're talking about here, which is glomerular filtration. So when we're monitoring this patient, we can do, the biggest thing that makes sense to this is we're talking about filtration, we're talking about fluid. So we want to think about the route of the I's and the O's, right? So what are some things we can do? We can monitor urine output, right? We can think about all the fluids they're intaking. So whether that's oral by their drinking, could be IV, could be something else that's going on that they're doing as well, any type of tube, things like that. So we're doing I's and O's. What would be some signs or nursing interventions that we want to be looking for? The patient has too much fluid. We talked about things like edema, so we're going to be checking the feet, right? But we also want to do what? We want to listen to the lungs. So we're going to auscultate our lungs, right? By auscultating the lungs, we're going to be able to hear some fluid, right? Be able to see if something else is going on. Does it feel tight? Are they complaining of being short of breath? We're doing the urine. We're listening, checking for any types of fluid overloaded. So we're also checking for edema, right? what else is going on? We talked about potential for the issues that could increase or decrease our glomerular filtration. One of those was blood pressure. So we're going to be making sure we're keeping a watch on the blood pressure, because that could also indicate blood volume, right? That could also indicate other things that are going on within the patient. And blood volume always goes back, right? I know. Because of that filtration rate being altered, we could have that increase in toxins. So we're going to keep an eye on that. What? Telemetry. All right, see what's going on with that patient. Keep an eye on their heart. The big thing they always like to hit on with the daily weights. What is it? You're probably screaming it by now. Our daily weights, right? So make sure we're 2 pounds per day or 5 pounds per week, right? That could indicate to us that this patient is potentially fluid overloaded. Hopefully it doesn't get to that point. You've noticed something else beforehand. We're talking about eyes and O's. We also want to talk about nutrition, right? So we want them to start talking to nutrition, nutritional counseling, right? Keeping an eye on that sodium, things like that. We also want to keep an eye on their medications. Remember, there's different medications that can affect kidney function, and there's also different medications that are affected by a kidney function. So meaning that if they aren't being cleared as quickly, then the patient could have a buildup of that medication within their body. So we want to make sure that we're talking to the physicians and making sure that we're aware of what medications are going to be okay for this patient. Because there's a change in that glomerular filtration rate, there may need to be a change in the prescription or the amount of the medication is given. And then we want to educate them. Essentially, the same things that we're doing in the hospital, we also want to teach them to be doing at home. So we're going to make sure that they are doing their diet right. So if they're on any type of special diet where they need to decrease sodium, right, or they need to increase something, more fruits and vegetables, we also want to make sure they know how to check for edema, right? So they want to be checking for things. Maybe in the morning, we're going to be looking at our ankles and stuff. Note if there are any shortness of breath. You want to make sure that you're calling your family doctor, letting them know, hey, I'm getting short of breath when I walk up the steps, or when I go for my daily walk, I'm not making it as far. And then that buildup of toxins, right? If we have some issues and a change in mental status. So because of that change in mental status, we're going to be thinking, is there a decrease in our elimination of waste, right? So is there an increase in our waste products? Meaning we're not filtering out what we need to filter out. So that, the special diet, also the I know. So that is where we want to start thinking to our patients, okay? These are signs that we need to generally start looking for. And then if you have any issues, you want to call your family doctor, call your nephrologist if you have one, in order for us to start figuring out what else is going on with you and what else we can do to help you get better, because we want to be able to fix this problem before it gets worse. Because remember, the lower or decreased our GFR goes, the more indicative of kidney disease we have. So in this video, we covered GFR, glomerular filtration rate. I hope you liked it. I hope you learned something from it. We're going to keep going through this series, and as always, until next time.